I can't even begin to tell you how happy I am. I'm happy because this is just a great place to be, with primary care, with innovation, with a very unique way to diffuse innovation through social media and doing it all in a Harvard classroom. It doesn't get better than that. And I'll tell you what else. After 40 years in primary care, I don't look that old, but it's 40 years in primary care, having Marcy saying that it's hip again is just the best. It's just the best. So, and I am happy. This has been a really exciting time in healthcare. We're really turning the corner. It's a time where we've become to embrace, or for the first time to embrace quality, to embrace population health, to embrace things that we didn't think about before in new and innovative ways, and redirect back to the patient. And it's just, I'm happy to be here, I'm happy to be alive through this epoch in healthcare. I'm happy because during the time that I'm in healthcare, we've crossed the digital divide. Hey, that's a good thing. I remember everything was handwritten records, right? And now 78% of all practitioners have electronic health records of one kind or another, but it's a big number. That's crossed the divide, that's major. I am also happy, I'll tell you, I am also happy because now the payment systems have changed. They've gone from, it's not a complete change, but they've gone from a strictly volume-based system to a value-based system. Value is now becoming much more important. So all those things are really good things. I'm really happy about that. And part of my role is to manage the performance within that. And as you all know, you can only manage what you can measure, right? And we're dependent upon, for our measures, for quality metrics, for population health metrics, we're dependent upon what reports we can get out of electronic health records and other databases. But in my world, it's predominantly electronic health records. And the information that goes into electronic health records in our world right now is a mixture. It's a mixture, as you know, of structured and unstructured data, probably in equal parts, depending on where you are, who you are, how you enter things, but an enormous mass, a sea of unstructured data. And that makes me a little sad, because in my job, I have to create reports, quality reports. And the quality reports indicate performance and guide future roles and future programs. And when the reports that come out of the standard EHR are incomplete because they only relate to structured data, it causes me great sadness. So I'm not sad at that point. I'm sad at that point. But that's changed. And how it's changed now in my world is that natural language processing is an innovative way to look at these records. With natural language processing, we're able to look at unstructured data, look at free text data, and extract that. Now, is that important? It is very, very important. In the study that we did, that I presented to you all, we looked at almost 3 million records, a 5-year retrospective study of 3 million interactions with providers. And the data from that was really pretty dramatic. And here, if you look at the red lines, those are information that came only from free text data. And the pale lines are what we got out of the structured data. And you can see the difference here in diabetes, COPD, depression, hypertension, rheumatoid arthritis, and kind of an aggregate overall, 25% in those defined conditions would not have been discovered. If you're doing population health, you can imagine what kind of a dent that puts into your information knowledge base about your population if 25% is blind to you in your reporting. Medication documentation for aspirin, hypertensive medications, smoking cessation medications, antidepressants, an aggregate of 36% were again blind because they occur in unstructured data. So what unstructured data is? The free text. We all use it. We're not able really to put all that data we're called upon to put into an EHR in structured fields. It's too much pointing and clicking. It would take too long. I've tried for years, for decades, to get doctors to do that. I've tried myself. It's impossible to document a complete record with just point and click, so we use shortcuts of various kinds of dictation. Free text is the best. Here's screening documentation, the same thing. Overall, 33% of screening documentation's parameters were improved by using natural language processing. This is really a way now to begin interoperability and collect accurate data. And when we don't collect accurate data, the first thing that happens is that we lose credibility with our providers. We lose credibility, we lose the ability to manage any kind of performance. And we can't manage performance, then we're back at square one. So all the technology in the world doesn't help you if the data isn't good. And this is simply one way to do that. And I see my time is running out. So I'll just slip through these couple of last slides. And say that health information technology is ultimately responsible to improve health. And the way we do that is with quality report cards, and we can't do it without good data. Questions?
Can you describe what a typical implementation of this kind of service would look like?
Certainly. So we do a merge of information data from the electronic health record, which includes all of the free text information. It's processed by the natural language processing programs and then returned essentially real time. So one of the other wonderful advantages of this is, number one, the ability to configure reporting in a very agile way. But the other is that it's real-time reporting. It's not, as it was in the past, sending my list of reports that I need to a developer who will then come back in a week or a month with some questions and then another edit and then some more questions. So this is really kind of real-time processing and very, very, the information that you give people should be accurate and it should be contemporary, and this solves both of these problems.
Natural language processing. Sounds so fancy. How much is it? Like, what's the cost implication for a practice? Is it just a standalone program they buy, or is it per patient? What's the kind of cost implication for utilizing it?
So this was part of a funded project. So I don't have an idea. We'll have to turn it over to some of the people who know more about that in terms of cost. But in terms of value, I can tell you the value is almost uncountable. The difference between having good data and bad data, if you can put a price tag on that, bad data is not worth anything. Good data is worth the world.
Thank you.
Thank you.